Hello, welcome to Mid1 Pager. My name is Benjamin, and we are beginning a new series, and this is going to be about the neonate. So if you're rotating in the NICU, or if you would like to remember something from the neonatal series, or if you're new to the pediatrics rotation and want to catch up and learn most of the vital things that give you a strong foundation to your NICU rotation, then here is something that you shouldn't miss. So when you look at newborn assessment, it's going to be something that is very critical to ensure survival of this newborn, especially when something goes wrong. So we have the rapid clinic evaluation. When someone has just been born, within the first seconds, you want to determine if there is a need for resuscitation. And this is very important. And the next video we're going to do is going to be right about resuscitation. So you want to do a rapid clinic examination. This is going to be within seconds, and this is going to determine the need for resuscitation. You want to see the term, the tone, are they breathing or crying, and if there is anything abnormal about this, you want to initiate the neonatal resuscitation protocol. So whenever we are assessing babies, we use the APGAR score, just like we have the TCS for the older children and adults. We have the APGAR score that we use to score babies, and it has these parameters that are basically an expansion of the acronym APGAR. So the A is for appearance, and we have scores from 0 to 2. So if they are pale or blue, this is very bad. This means the oxygen is out of the hemoglobin, so you're having a lot of deoxygenated hemoglobin being lost. We're not having good oxygenation of the body, and we score that as 0. And we have acrocyanosis, which is a bit of cyanosis on the fingers. That is a 1. And then if the baby is pink or the baby is looking really good, then you want to give them a 2. Then we have the pulse. You want to determine, do they have a pulse present or absent? And if it's absent, that's a 0, obviously. And any pulse less than 100 in children is a sign that things are not going well. And when we're doing resuscitation, whenever the pulse goes below 100, we want to initiate resuscitation, because whenever a baby is having issues with their breathing and everything, the heart is going to slow down. And if the heart rate is greater than 100, then you want to score them at 2. Then we have the grimace. If there is none, if they are not grimacing over anything, then that is a none. If they have a weak grimace, they're trying to like show kind of discomfort and everything, that's a weak grimace. That's going to be a 1. And then if they're having a good strong cry, then you would consider giving them a 2. Then you want to see the activity. If they are limp, they're not doing anything, that's a 0. If they are able to flex their body, they're having maybe some little flexion, that is going to be a 1. And a 2 is when they're active, moving about, and they're normal. Respiration is going to be absent, slow, or good cry. So when you look at the APGAR score, sometimes we do a generalized kind of classification, whereby 0 to 3 severe distress, 4 to 6 is a moderate, and then a 7 to 8 to 10 APGAR score is reassuring. And of course, you have to make sure you know things like the reversing of the APGAR score, where a child may score a 10 now, but in the next few seconds, or in the next minutes that pass, they go ahead and score about an 8. So this is something that you should always look around for. Then we have the vital signs. The heart rate of neonates is a bit higher than the normal adults, and that's going to be about 120 to 160. The respiratory rate is also higher, about 30 to 60. Temperature is going to be between 36.5 to 37.5. And then the blood pressure is 60 to 80 over 30 to 45 millimeters of mercury. You want to go ahead and do anthropometry, and always when a baby is born, one of the first things we do is weigh them. So when we are weighing them, we are looking at the weight, the length, and the head circumference, and then we plot them on their growth charts. So you find that we have small for gestation age. If their weight is less than the 10th percentile, we can have things like large for gestation age or average for gestation age. So if they are greater than the 90th percentile of children, then you have a large for gestation age baby. Especially you look out for these in mothers with diabetes. So when you look at the head, or when you try to give them a neurologic examination, of course, you won't really test their cranial nerves, because they don't have very good ability to follow instructions. So you're going to go ahead and do a neuro exam that is more subjective, and you want to look at the molding. Molding, this is the overlapping of the bones of the skull. So you know these bones are not yet fused, so sometimes to pass through the birth canal they have to slide over each other, kind of overlap, so that the head becomes a bit smaller. Then we have caput subsidium, and we shall look at these when we look at birth injury, but this is basically bleeding within the scalp. And then we have a cephalohematoma, which is also like this, but the differences are between the region between where the blood is seated. For caput, it's going to be crossing sutures, and for a cephalohematoma, it's not going to cross sutures. And if you ask me which one is more deadly, I'll tell you it's the cephalohematoma, and we shall see why. But if you know why, then feel free to drop it in the comment section. Also, if you watched this far and you have not yet subscribed to the channel, please do consider that, because we are going to do this for a while. We are going to have these high yield topics being discussed. We already have a number of videos on the channel discussing very important concepts for any medical student to understand. Then we have the fontanelles. We have the anterior fontanelle that is diamond shaped, and sometimes we have things like bulging of the fontanelle, especially when the intracranial pressure is increased. In children who have things like meningitis, if they have hydrocephalus, you find that they have a bulging fontanelle. Then we have a sunken fontanelle, which is most of the time going to be an illustration of dehydration or a diminished intravascular volume. Think about a child who has been probably bleeding, maybe due to a lesion or something. They could have a fontanelle that is depressed. So when you look at their general appearance, you want to look at the color. If they are pink, that is a good thing. Cyanosis, think about a cardiac or respiratory issue. If there is pallor, think about anemia or shock, because they bleed out. Sometimes you have things like abruptio placentae, where the placenta may be abrupted, and this neonate went ahead and bled a lot. So we can have things like jaundice when we have hemolysis or hemolytic disease of a newborn. Sometimes it can be liver, or even immaturity can be a cause of jaundice, because the liver takes a bit of time to mature and produce enough enzymes that can break down this bilirubin as fast as possible. So sometimes immaturity alone can cause the jaundice. So we look at their posture. If they are flexed, that is a good thing. If they are not flexed, they are hypotonic. They are flabby. A flabby baby is a sick baby. Then the activity, if they are irritable, then that could be due to a withdrawal. Sometimes it can be due to hunger. When a child is hungry, they're going to cry a lot. But for mothers who are using drugs, sometimes when the baby is in the uterus, they receive these drugs, and when the mother is born, or when the baby is born, there's withdrawal. So the baby experiences withdrawal syndrome. Then lethargy can be coming because of sepsis as well as hypoxia. So when you look at the skin of the baby, most of the time we have the vernix caseosa, which is that slippery jelly-like thing that is on the baby, and this is very important. The vernix kind of protects the baby because the uterus is a liquid environment, and the baby being coated in this vernix helps protect him from that maceration that would occur because of exposure to the liquid. We have lanugo hair. Then we have the milia. This is a very mild rash that can be found on the baby. Mongolian spots can be normal, and sometimes you don't want to say it's abuse or something like that. And then we have pathological things like petachia, which is the bleeding. It can be due to infection, or it can be due to thrombocytopenia, which is decreased platelets. We have the cafe au lait spots, and these can be associated with neurocutaneous syndromes, and these are very important to know because they could bring about problems that are very highly specific. Then we can have the hemangiomas, which are venous or vessel malformations on the child. When we look at their face, we're looking for dysmorphic features. We have features like a flat nasal bridge, which could point to Down syndrome. Lucet ears could also point to things like Down syndrome and other chromosome abnormalities. When you look at the eyes, we have the red reflex, and this is very important because when you shine your light into the eye of a child, it's supposed to give back this red light, this red reflection. If it doesn't, then we may have a cataract going on, and worst of all is a retinoblastoma, which is a kind of aggressive tumor of the eye. due to that mutation in the RB gene, which is the retinoblastoma gene. So sometimes we have the subconjunctival hemorrhage, and this might be maybe benign. So you may find this baby who is born with a blood spot in the eye. Most of the time, this is going to be benign, and you may need to reassure that mother. So the ears, their position is important, and also sometimes hearing is important to be assessed. You may find that this child probably does not hear very well. The nose, we want to really make sure it's patent, because we have this choanal atresia whereby the choana or the nose, the holes in the nose do not go ahead to open. So when they don't open, this child is going to always have cyanosis. But when they cry and open their mouth, you find that the cyanosis improves. In the mouth, you want to look for cleft lip and cleft palate. Sometimes it's obvious, sometimes it's not obvious. Then the Epstein pulse, and these are benign. And then the tongue tie, which is called ankyloglossia, and this one is going to affect the way they breastfeed. They're going to be making sounds while breastfeeding, and this is because of the way the tongue is held down and impeding the suction very well. Then when we go to the neck, you want to rule out things like webbing of the neck, internal syndrome, and then we have sometimes masses like cystic hygroma. We already did a video about this, and it is in the surgery playlist as well as the pediatrics playlist. So when you look at the chest and respiration inspection, you are going to do like you do in an adult. You want to do inspection, and then you want to do auscultation. Look for the symmetry, look for retraction, nasoflaring, or anything that would signify respiratory distress, and then go ahead and auscultate the breath sounds, added sounds, and then common pathologies affecting the chest or the respiratory system in children are things like transient tachypnea of the newborn. We have respiratory distress syndrome due to a decrease or low volumes of surfactant, as well as the pneumonia. Then another thing we can look at then is the abdomen. The abdomen is below. It should be soft and undistended. Look out for things that point to pathologies. Things like an obstruction could be important. Things like masses, and also the liver. Then the umbilical cord should have 2 arteries and 1 vein. When you find a single artery umbilical cord, they are associated anomalies. And if you know the associated anomalies, I would urge you to put them in the comment section. I'll be glad to see them. But if you don't worry about that. We shall probably do a video covering something about it. Then the genitourinary system, you want to see how the testes descended, but sometimes the testes take a little bit of time to descend actually, and they may not be descended at the time. Look for things like hypospadias or epispadias. This is where the position of the urethra is abnormal. It can be below on the shaft and things like that. Then in the female, look for labial swelling and well as vaginal discharge. Sometimes even babies can have bloody discharge, and that may come from maternal hormones and things like that. I won't go into that right now, but it should be something that you could find somewhere. Then the anus, patency is important to be established, because we may have imperforate anus, and that is an emergency. So sometimes you're advised to maybe glove your finger and try to see if the anus is patent. The limbs and musculoskeletal system, look for symmetry, range of motion, and fractures. Fracture of the clavicle is very common, but sometimes you may find that this child is actually moving one side of the body. Probably they're not moving a particular limb because it's broken and things like that. And remember, they can't complain, so it's upon you to always look out for those things. Then we do the hip exam, where we have the otoloni and the Barlow tests. And the Barlow test is kind of like this. You are pressing down on the hips to see if there is posterior displacement of the hip, and then the otolani, you are moving it outwards to see if there is that displacement of the hip. And these are used for assessing the developmental dysplasia of the hip. Sometimes you have abnormalities in development of this hip, and you need to do the Barlow and the otolani tests. When you do the neurologic exam, look out for things like tone. Flex tone is good. Flabby baby is not good. You want to do the reflexes, and babies have a set of high yield reflexes. Not the moral reflex, not the rooting reflex. The moral is when you kind of like hold the baby in a safe way, and when you try to drop them, you see as if they're trying to hang on to their life. They're trying to grab whatever they can in the air. That's the moral reflex. We have the rooting reflex, and this one is going to occur when you try to put something on the cheek of a child, they turn and try to suck. They think it's a boob, it's a breast. Then we have the sucking reflex. And for the sucking reflex, it's going to be where you put a finger within the mouth of the baby, a clean gloved finger, and you find that the baby tries to suck it. Grasp reflex is going to be when the baby, you put your finger within the baby's palm and the baby tries to grab it. We have the stepping reflex, where when you put the baby on their toes, they try to step. And then we have some abnormal reflexes that you may find occurring that point to CNS pathologists. Hopefully we shall do a video about these reflexes. The red flags that shouldn't miss are things like persistent cyanosis, poor feeding, lethargy, abnormal cry, respiratory distress, temperature instability, seizures, as well as vomiting. So how do you think about this? Clinically, you want to, when a newborn is being assessed, you want to think in layers. Is this baby stable? If they're stable, are there any life-threatening issues? If there are no life-threatening issue, do they have any congenital abnormalities? Do they have any metabolic or infectious risks? And what needs monitoring and intervention? And once you cover that, then most of the time you're going to be doing a full assessment of these children. So we have come to the end of this video. It has been a lot being discussed. And we're going to continue with this series about the newborn or the neonate. I would love to see you posting your comments in the comment section, leaving a like, asking what you want clarified. You can also tell me what you would want me to discuss next. And until next time, my name is Benjamin, and this is Med One Pager. Have a nice day.